speaker. Professor Sabino Luzzi from Italy, and he will speak about the management of posterior circulation aneurysm.
Can you hear me, Professor?
Yeah, perfect. Yeah.
Can you see my screen?
Sure, it's okay.
Okay, thank you so much. Thank you so much once again. It is my best pleasure to be here today, and I have not enough words to say thank you to Professor Zileli and all the speakers and for this kind invitation, World Federation. It's an honor for me to be here to talking about my humble experience about the management of posterior circulation aneurysms. My first slide focus on the natural history of posterior circulation aneurysm, and this is what we know today about posterior circulation aneurysm, and the natural history of this aneurysm is particularly dismal, especially in terms of giant aneurysm, and we can see here has the 5-year cumulative risk of bleeding, especially for giant aneurysm reached 50%. So it means that half of the patient that we diagnose today will bleed. So there are no question about the fact that there is a clear indication for most of these posterior circulation aneurysms. And this is an overview that summarizes what are the main features of what we call today complex aneurysms. And if we take a look to the posterior circulation aneurysms, we see that most of them hold the same features that we, listen in the field of complex aneurysms. So practically speaking, it means that most of the posterior circulation aneurysms can be considered as complex aneurysms because of the architectural features and because of the narrowing corridors that we deal about, and also because of the atherosclerotic changes that usually occur at the level of most of these aneurysms. And this is an overview of the treatment option that we have today for intracranial aneurysms in terms of open surgery and in terms of also, coiling and the most recent pipeline and the flow disruptors, Web, Luna, and so on. And this is an overview of an article about our personal institutional experience. And here it is the series of my previous chief, Professor Galcio, about posterior circulation aneurysm, about critical appraisal. We titled with this article in a surgical series of in endovascular era. And we recently reviewed 20 years of his main experience with an average age of this patient. And 98 aneurysms were ruptured in this series, and 155 were surgically treated with a very long term follow-up. And if we see about the incidence, we saw that the most of them occur at the level of the quadrifurcation of the basilar tip. And then we have the V4 intradural segment of the vertebral artery, and then VBJ and proximal pica, and then mid-basilar trunk that fortunately are the most challenging one, but are also the most rarest one. And if we take a look to the distal aneurysms prevalence, and these distal aneurysms are very important because they are suitable for surgery in most of the cases today. In our series, the most frequent were the posterior cerebral artery, and then the pica, and then the ICA, and then the SCA that are important also. And this is an overview of the technique that we use in treating this kind of aneurysm in terms of posterior circulation aneurysm. This is an overview, and in most of the cases, they are suitable for clipping and clip reconstruction of as a technique, and these are the main overall results of surgery when we talk about posterior circulation aneurysms that are totally, offer an overview of the results of surgery. Okay, this is our only personal institutional experience, but these numbers are in line with what we found in the literature, and most of these aneurysms are, treatable with surgery with a modified ranking scale ranging between 0 and 2. That means an overall very good outcome. We also focus on the pica series, and pica still today is one of the most important and suitable aneurysms for surgery. And we recently reviewed, our 10 years experience with 25 aneurysms surgically treated, but all of them with very long, very good follow-up. And here we can see when we look at the pica series that the segment prevalence was toward the most was toward an higher incidence in the proximal, so-called proximal aneurysm are the vertebral artery pica, proximal pica, anterior and lateral medullary segment of the pica also. And also for this kind of aneurysm, in most of the cases, they are suitable for surgical clip ligation and rarely with pica to pica in situ bypass. This is a small aneurysm, but this is proximal aneurysm. This is incidental. This is, not suitable for calling, in my opinion, because it is very close to the takeoff of the pica, vertebral artery pica aneurysm. So it's better to treat this aneurysm with surgery, and this is the results. And this is another one that is very distal. We perform here a paramedian suboccipital approach, 1 year of surgery, and you can totally exclude aneurysm here, despite it, and no way, at least in my humble opinion, about the fact that, these are very, very, treatable with surgery and with very good results. And this is one of the articles that I published when I was very, very young. This is one of my first, and we described an extracranial aneurysm of the posterior inferior cerebellar artery. They are very rare, but there is a red flag for this kind of aneurysm because there is the need to perform the 4 vessels digital subtraction angiography. We need the bilateral vertebral artery injection because otherwise we risk to miss this kind of aneurysm, both them that are considered extracranial and extradural. This is the overview of the outcome in terms of total and especially durable exclusion rate of these aneurysms. And once again, most of them consider that this series is most serious with most ruptured aneurysms with hematoma. But despite this, in most of them, more than half, they have very, very good outcome with surgery. So it means that nowadays we have enough data in the literature and also in our humble experience to justify microneurosurgery and to sustain the role, the critical role that microneurosurgery still have in the treatment of posterior circulation aneurysms. I want to take a look, and I want to focus just for young neurosurgery about some technical aspect. Neurosurgery was born with the transcisternal approach. Recent modern microneurosurgery was born with Professor Yashargi and transcisternal approach, and he gives born to the microneurosurgical area. Why? Because he taught us to navigate the system to reach the different part. And another important aspect is the planning of this aneurysm. It's very important, CT angio, 3D CT angio, but it's mandatory to perform also in most of them MRI, especially in the thrombosed one. If we planned to perform a bypass, it's super important to perform 6 vessel digital subtraction angiography involving also the injection of the superficial temporal artery and occipital artery, especially in terms of posterior circulation aneurysm. And today, there are no doubt about the critical role of baseline about the neuromonitoring during surgery, especially brainstem auditory evocate potential. We use a very, very huge, landscape of positions, semi-sitting, prone, supine, whatever you want, and the Concord, 3/4 prone. It depends by the approach that you want to perform, and it depends also by the preference of surgeon, but the basic principle of positioning of the patient are the same. You have to be, sure to allow for a very good outflow from the cranial district. And we have to know when we approach this aneurysm beautifully the anatomy in terms of not only normal neurovascular anatomy, but especially for variation, because we have lots of variation, especially at the level of the posterior circulation aneurysm, especially at the level of the pica. The pica is the most important, most variable artery inside the brain. And we also have to know, some feature about the variants. And here, for example, this is a super high riding basilar tip aneurysm that we have to know before to choose the right approach. This is an overview of the factor that I personally consider when I plan approach for a posterior circulation aneurysm. In my opinion, 3 main aspects should be taken into account. The first one is the need for exposure to the aneurysm. The second one is the proximal control that we want to have to the aneurysm, and the second one to the parental vessel. And the third one is the strategy. For sure, is totally different if we plan a bypass or trapping on the clip reconstruction of the aneurysm and so on. So this is an overview, especially for young neurosurgery, about the transcranial approaches that we usually can perform for anterior, but also especially posterior circulation aneurysm. And we see here the amount of the exposure in terms of clival and related area when we approach this kind of aneurysm. And this is an overview of all the approaches that we routinely use for posterior circulation aneurysm. And as we will see very soon, pterional and COZ approach that are anterolateral approach have a critical role, especially in basilar tip quadrifurcation and basilar tip aneurysm. And this is what we have and what we can do to expose this kind of aneurysm. Focusing on basilar quadrifurcation aneurysm, depending by the preference of the surgeon and the riding of the aneurysm, we can use these three kinds of, approaches: pterional COZ, anterolateral approach, subtemporal transtentorial, the classical Drake approach, and today some authors also suggest the use of subtemporal transpetrosal approaches, the so-called Kawase approach. And we have to take account also that we have lots of variation in terms of anterolateral approach that allows for variation in terms of bony exposure, but also corridors, intradural corridors exposure. And we can tailor some of this approach to treat basilar quadrifurcation aneurysm also. And in this recent article, I review what are the tips and tricks to tailor the approach in this kind of aneurysm also in terms of superior circulation. This is an overview of the intradural corridor that we can use for basilar quadrifurcation, basically transylvian, subfrontal, pretemporal, subtemporal, also in so-called half and half. And also in this, critical, there is a critical role of optopterional, especially COZ approach, cranio-orbitozygomatic approach. This is an article that I recently published about how to tailor this approach. And in this article, it is very well described that the zygomatic arch is the key to fully expose the basilar quadrifurcation. As I will show here, this is just a draw to show you how can increase how the angular exposure to the target, and the target here is the basilar tip, can be increased. Here we have the basilar tip aneurysm with the brainstem, and also we have the zygomatic arch. And what we do here is the critical exposure in terms of, interpeduncular fossa here going through the zygomatic arch, because the amount of increase in terms of angular exposure has been estimated to reach the 50%. And also we have pterional pretemporal transcavernous that can be used for normal riding and low riding aneurysm, COZ that can be, as already told, beautiful use for so-called high riding aneurysm. And this is an overview of the intradural corridor, especially to the P1 proximal segment and the interpeduncular fossa about and in doing this, we use some deep windows, the so-called deep windows between, for example, carotid oculomotor, oculomotor tentorial, and so on. And most of them are related to the transsylvian perspective, and other of them are related to pretemporal, subtemporal, like COZ approach. And this is a case, for example, of basilar tip aneurysm that was here. Three different corridors were used, 1, 2, and 3, opticocarotid, carotid oculomotor, and supracarotid corridor to treat this complex aneurysm. And don't forget the role. This is a case of, of my mentor, Professor Galzio, that was a master in terms of he popularized the so-called endoscope-assisted technique, and this is endoscopic assistance of the posterior circulation, the SCA aneurysm. With this technique is beautiful to spare, here thalamo-perforating artery in this area for these aneurysms that are very challenging. And also, this is a pre-op and post-op, and this is an overview of, anterolateral approaches that their role for posterior circulation aneurysm. We see that up to 23% of aneurysms in our series were treated with the so-called extended pterional approach. That means maximize the exposure in terms of drilling of the lateral sphenoid wing. Mid-basilar trunk and vertebro-basilar junction. Today, there are very few indications for this kind of aneurysm. For sure, these aneurysms are 99% suitable for endovascular treatment, but just to know that the exposure of these aneurysms can be done with combined petrosal approach, but we have a role still for surgery, critical role for proximal pike and vertebral artery. As I showed you in our personal series, they were the most frequent. And far lateral and extreme lateral approach are beautiful approach for this proximal pike aneurysm. And this is a case of giant vertebral artery pike aneurysm that was treated with clip reconstruction, totally sparing the takeoff of the pica here, and the patient went so well, and this is a pre-op and post-op. And this is the final result without condylectomy here, because a transcondylar fossa approach especially was performed, sparing the condyle. And this is an overview, once again, of the approaches that we can use, especially to approach the vertebro-basilar junction system, so the lower third of the posterior circulation here. And this is the exposure of the pica and the proximal anterior and lateral medullary segment of the pica. These are the key steps of our lateral approach. Just a trick, don't forget to put the patient in this position, because this is, the tip of the patient should point to the floor, because this is basically an infrajugular tubercular approach. And don't forget, and also during the skeletonization of the vertebral artery, up to 25% of vertebral artery pica can take off from the vertebral artery in its V3 part. And this is the difference in terms of exposure. Transcondylar approach is beautiful, and it offers more shallowing and a more flat view to the vertebro-basilar junction here, just in case. And this is an overview of the corridors that we can use. Especially, we can describe two corridors. The first one is above the hypoglossal nerve, and the second is below. The so-called suprahypoglossal corridor is the corridors of choice to treat the anterior medullary segment aneurysm, and the so-called infrahypoglossal corridor is the corridors of choice to reach the lateral medullary segment, the caudal loop of the pica here. And also, we can use the suboccipital approach with all of these variations for treating beautifully the pica, the distal pica aneurysm. The suboccipital approach can be the different, shape in terms of craniotomy, and this family of approach can be also tailored. We have three different intradural corridors, median, paramedian, and lateral. It depends basically from where the aneurysm is located. And here we work around the tonsil, especially the tonsillo-uvulary fissure approach is, the corridor of choice to treat those aneurysms that affect the TUFA approach. Tonsillo-uvulary fissure approach is the corridors of choice to treat the so-called cranial loop, or the telovelo-tonsillar segment of the pica here. And the distal pica also can be beautifully treated with also the retro-sig approach. Distal SCA, ICA, and pica can be also treated with the retro-sig approach. I want to conclude my lecture with a slide of Professor Splezze that always say that especially in skull-based surgery and neurovascular surgery, they share the same principle: exposure is everything. Thank you so much for your kind attention.
Thank you, Professor Sabino Luzzi. It's an excellent presentation, and as your conclusion, is it true that we need to teach a young neurosurgeon how to make approaches, because it's very important, especially in posterior circulation aneurysm. I know they are maybe one of the rare departments that still continue to operate this kind of location. Thank you. So now
I totally agree with you, 100%, as I told you.